Now, as you can imagine, these lesions can be challenging. There is actual or potential airway obstruction, or there is potential or actual loss of the airway, where you will lose the airway. There will be difficulty in ventilation, intubation. You often have to share the airway with the surgeon, and there is a chance of post-operative airway compromise even after the surgery is over. So when we look at the preoperative assessment of these patients, we need to keep in mind that most of these patients are often elderly. They will have all the problems related to old age, ischemic heart disease, COPD. They've got chronic use of tobacco and alcohol, and therefore cardiopulmonary disorders will be significantly present in many patients. In major intraoral tumors, if the tumor has interfered with eating, there could be weight loss, malnutrition, anemia, dehydration, electrolyte imbalance. And we also need to know that many of these patients have received therapy in the past. They could have been operated earlier, they could have received chemotherapy, and a large proportion of patients nowadays receive what we call as neoadjuvant chemotherapy or chemotherapy prior to surgery. And they may have also received radiotherapy. So they need to be aware of the effects of these treatments, especially the chemotherapy and radiotherapy. One of the features of cancers in developing countries like India is that many present at a late stage, and these sort of lesions which you see here may probably be unheard of in the West, but these are not uncommon, and many of these patients present with huge tumors and often fungating or lesions which are just far too big and bulky and pose all sorts of problems. Previous surgery can present several problems to the anesthesiologist. As you can see, if there has been some excisions of some parts of the facial structures, you could have a difficult mask fit, and face mask ventilation might be difficult. You could have microstomia and reduced dimension of the oral cavity. The teeth, if the mandible is removed on one side, but the teeth are present on the other side, they can sort of pose a problem for laryngoscopy. You find it difficult to insert and manipulate the laryngoscope. If the lesions are on the right side and there is some fibrosis or something which has happened as a result of surgery on the right side, you could have fibrosis and difficulty in manipulating the tongue and epiglottis. If there have been, especially also if there have been bulky pedicle flaps which are present in the oral cavity, which have been put there for reconstruction. So these problems will make airway management difficult. Prior radiation therapy also is quite difficult, can make life quite difficult for us. So you can have mucositis, the temporomandibular joint could be fibrosed, in which case you could get trismus, which doesn't really relent after giving a muscle relaxant. Teeth are badly affected, you could have caries, and these teeth are extremely brittle and could fall off with minor trauma. You have glossitis, and the tongue might be enlarged with edema, again making laryngoscopy and visualization difficult. There is fibrosis at the floor of the mouth, and the mandible may be osteonecrosed, and you will often have indurated feel of the tissues over here. And if you have induration or rigidity of the tissues here, you can almost certainly expect that the tissues inside, when you put in the laryngoscope blade, will be extremely difficult to move, and you will find it very difficult to retract or to lift the tissues up when you do a direct laryngoscopy. Okay, so you could get fibrosis and edema, and sometimes this induration and rigidity of the tissues externally give you a clue as to that. And you could have edema of the glottis and epiglottis, which makes the airway caliber quite narrow. So radiation therapy is something which can make airway management difficult as well.